Okay, so again, welcome everybody. Thank you for taking your lunch hour out to join me today. I'm going to be talking through some nutritional strategies to help polycystic ovary syndrome. Right, this is an increasingly common disorder that affects women primarily in their reproductive years. And it's believed to affect about 5 to 10% of women worldwide. It's characterized primarily by at least 2 out of 3 classical features. So anything through from androgen excess to ovulation issues, and these include anovulation, so when the ovaries don't actually produce an oocyte at all, or oligo-ovulation, which is sort of infrequent or irregular ovulation. One of the sort of characteristic features of the syndrome, which kind of reflects in its name, is the presence of polycystic ovaries containing large numbers of harmless follicles that are sort of oversized, so that they're slightly larger than normal. The issue, obviously, with polycystic ovary syndrome, with the sort of androgen excess and the lack of ovulation, is that many women have difficulties conceiving. And it's quite common, actually, for a lot of women with PCOS to not actually realize that they have the syndrome until they find that they've got difficulties conceiving. So they go to their doctor, have a little chat there, and then there's sort of a kind of formal diagnosis is made. But so there's a lot of people walking around with polycystic ovary syndrome who don't know they've got it. But if by the end of the webinar, I'm hoping you'll be able to kind of spot them a little bit. So I guess the issue as well is that it's not just about fertility issues. So we think of polycystic ovary primarily as kind of a fertility issue, but actually individuals with PCOS quite often will have metabolic disturbances, cardiovascular issues. They often have type 2 diabetes or certainly metabolic syndrome, high levels of visceral obesity. They've got endothelial dysfunction, and they've got an increased risk of cancer, especially of breast, ovaries, and endometrium. So I guess the issue really is that we don't just look at sort of PCOS as a fertility issue, but it's actually quite a major health problem. So sort of identifying individuals who may be at risk or maybe have the syndrome is really worthwhile to be able to then sort of implement some dietary changes and some interventions that can help manage the condition. And there are some aspects of intervention that hold an awful lot of promise, and I'll be going over those towards the end of the webinar itself. So let's just have a look at exactly what's going on. So one of the issues is focusing around androgen excess. So with PCOS, we see that there is this increased frequency of gonadotrophin releasing hormone. It releases pulses that increase in luteinizing hormone secretion. So usually, in a normal situation, we have levels of luteinizing hormone and follicle stimulating hormone that are about 1-to-1 ratio, so they're on par with each other. In a normal situation, we would see an LH surge around about 24 hours before ovulation, and then LH then returns back down to normal. But with women with PCOS, they have much higher LH than FSH. So sometimes the LH is quite high, or it can be within the normal range, but it's the ratio of LH to FSH that is out of sync, so often as high as 3-to-1. And it's this LH pulse frequency that then occurs, and it's kind of considered to be around about 1 LH pulse per hour. So that there's no LH surge. If you don't get an LH surge, you don't get ovulation. So you get this sort of flat line of LH rather than this surge. When we look at levels of androgens such as testosterone, PCOS individuals tend to have high levels of both total testosterone and free testosterone. So normally testosterone is sort of chaperoned around the body by this protein called sex hormone binding globulin. And if you have low sex hormone binding globulin, then you have high levels of free androgens, and in this case, it's testosterone. In women, even a slight increase in testosterone can impact on normal menstruation and ovulation. When it comes to estrogen, if we look at the follicle itself and the cells within the follicle, the thecal cells, they don't produce estrogen, but they do produce androgens in response to LH. These androgens are then converted into estrogen by follicle-stimulating hormone-induced aromatase. So this is the enzyme that converts through to estrogen, and this is the cells in the neighboring granulosa cells. Now, low follicle-stimulating hormone, which we see in PCOS, results in high levels of androgens secreted from the ovary, and this leads to a failure of the follicle to develop and progress. So now we've got a nice little picture to sort of show you, to sort of re-emphasize it. So on the right-hand side here, we have the normal kind of situation, and on the left-hand side, we can see that due to low levels of follicle-stimulating hormone, we don't get interaction through granulosa cells, so the androgens don't get converted into estrogen as they would in the normal cycle, and this is where the kind of issues that we get. The other factor that plays a role in PCOS, which I'll go over in just a moment, is high levels of insulin. And high levels of insulin can also increase androgen. And it's this high levels of androgens, primarily testosterone, that are associated with some of the kind of like physical characteristics that we see in polycystic ovaries. So quite often we can see things like facial hair and hair on the body, and acne as well is one of the sort of prominent features of people with PCOS. So that's kind of what we're seeing here, and then we've got a little diagram at the bottom to show the ratio of LH to FSH is out of kilt in regards or in comparison to the normal menstrual cycle. So we're not getting this lovely little LH surge that we would need to get our little egg released here. So generally, PCOS women either do not ovulate or have very infrequent ovulation. So obviously fertility is going to be a prime issue here. As we can see on our next slide here, when we're looking at our associated health issues. So, like I said in the introduction, we think of PCOS kind of primarily as this issue with infertility. But actually, there's a whole kind of mesh of other issues that we can see here. A lot of the time, women with PCOS have issues with weight gain. They find it very difficult to lose weight. And quite a high proportion of women with PCOS are actually obese. Obviously, then we can link the kind of obesity through to metabolic syndrome, and then that leads us through to type 2 diabetes. So it's this kind of presence of visceral fat as well. So we can kind of look at the sort of pear shape, apple shape, typical sort of visceral obesity. Obviously, another thing to sort of take on board is that sort of visceral fat itself is primarily very pro-inflammatory. So then we have the issues with metabolic syndrome leading to type 2 diabetes. Some of the sort of characteristics of metabolic syndrome and type 2 diabetes are obviously with high cholesterol, high lipids, things like that. This leads us through to an increased risk of things like cardiovascular disease and stroke. That then leads us through to increased risk of dementia. When we're thinking of the sort of cardiovascular side of it, we link that through more to sort of vascular dementia, although Alzheimer's is still going to be a bit of a key because of the role that insulin plays in insulin signaling within the brain itself. I'll have a little chat about that. And then we've got all of our kind of hormone-driven cancers. So as I said, women with PCOS are at an increased risk of endometrial, ovarian, and breast cancer. Also linking through, again, back to things like metabolic syndrome. We have an increased risk of developing non-alcoholic fatty liver disease, itself very pro-inflammatory. And then we've got other issues. Okay, so these are kind of characteristic of sort of obesity-linked health issues. So just the sort of very weight of sort of carrying that excess weight can have issues on sort of joint and bone stability. And then for those women who do conceive, and it is not, I mean, it's not common, but it's not to say that all PCOS individuals are never going to conceive. So some do. But those who do, or who are fortunate enough to conceive, then have an array of potential pregnancy complications. So we're looking at things like miscarriage, gestational diabetes, and then when we look at those women who carry their babies full term, we run the risk of either having a low for gestational weight gestational age, baby, or preterm birth, so babies who are just born a little bit early. So then, these children are going to have their own sort of set of sort of issues as well, long term, possibly. Okay, so there's lots of health issues that we need to be dealing with. And we're all familiar with each of these as sort of individual units on their own. And we know that each of these can be modified through diet, and often supplementation can be helpful as well, and exercise and stress reduction and those kind of things. So we know that we can modify all of these factors, and we can modify a lot of the factors that are actually directly related to PCOS, and we can do it to an extent where we can increase the chances of actually conceiving. So it's quite positive.
Yeah, I was just wondering if I could...
I might have to just turn my volume up. I'm not sure I can hear you very well.
No. Yeah.
Hello?
Oh.
Who's talking? Sorry about that. I've got somebody coming in the background. Oh, I see. Right. Okay. So Sophie's very kindly just asking Kate to turn her phone down. Right. Okay. So let's move on. Okay. Some of the signs and symptoms. Right. Okay. So some of these are quite obvious. Things like weight gain that is difficult to manage. But a lot of individuals with PCOS have issues with fatigue, low energy, poor sleep. In fact, sleep apnea is quite common in women with PCOS. And then we've got our unwanted hair growth. And this isn't just on the face, but it can be on the arms, the backs, even the toes for some reason. I'm not quite sure why that is. So basically all over the body, really. So for a lot of women with PCOS, some of the sort of like physical characteristics can themselves be quite distressing. We then have, later into middle age, we have thinning hair on the top of the head. I've obviously mentioned infertility, leading cause of female infertility, certainly. And then we've got issues with acne. And then there's some other sort of characteristics. So we get these little skin tags, these little bobbles that are quite often around the neck. And we also have darkened patches of skin around the neck as well. And this is due to increased epidermal keratosis, sorry. So basically, yeah, I'm going to talk about that a little while later as well. So this is all about sort of growth factors and too much growth factors and that kind of thing, and then how we can modify that as well. Women with PCOS have a tendency for mood swings, depression and anxiety. And then when it comes to sort of monthly cycles as well, there's a lot of pelvic pain, quite often heavy bleeding, and quite often headaches as well. So whilst a lot of women don't actually receive a formal diagnosis, there are these key characteristics and quite a few sort of very physical characteristics that can be sort of made and almost like an observational diagnosis. So when we have people coming to us, and they might not even be coming to see us for issues related to infertility or anything like that, there are sort of key things that we can kind of be looking for, and then maybe sort of guide them to seeing their GP to have a formal diagnosis. So, right. So this is the kind of area that is really hard to get your head around a little bit, because when we look at the causes, or what's going on with PCOS, there is such a strong link between obesity and PCOS that it's quite tempting to say, well, okay, is obesity and diabetes and those kind of areas the cause of? And the evidence suggests that actually, no, it's not, but it does exacerbate the symptoms. The kind of research points to some other areas, though. So there is a genetic contributor. So we know that if you have female relatives, obviously female relatives, with PCOS, then it may be that you are going to be at a higher risk yourself. There is evidence to suggest that actually testosterone exposure in utero may predispose women to later development of PCOS. And then there's kind of our environmental and lifestyle factors. So this is kind of linking through again to sort of sedentary lifestyles, eating the wrong foods, and, all of these sort of dietary and lifestyle factors that can predispose us to sort of weight issues, obesity, that can then link through to hormone issues as well. So there's a kind of areas that we are familiar with that can sort of drive PCOS. But like I said, it's very encouraging that we, if there are environmental lifestyle factors that can be modified, that we can either reduce the risk of developing it, or we can modify it and help improve a lot of the symptoms that are associated with PCOS. So when it comes to the sort of current interventions, and I'll just go through this very briefly because it's all about pharmaceuticals, and we're here to talk about nutrition and diet and lifestyle and that kind of thing. But the kind of early interventions are really kind of focusing on insulin, glucose moderation. So we use there's the drug metformin, which is used by type 2 diabetics to moderate insulin sensitivity and regulate glucose intolerance. This can help at an early step through sort of the insulin resistant stage. Then when we're looking at sort of androgen excess, even something as simple as the estrogen progesterone oral contraceptive, this can be used to regulate menstrual cycles. This is quite helpful in women who have sort of very heavy irregular menstrual bleeding, etc., etc. Then we have our anti-androgens, so we're moving down to these drugs here. These are actually commonly used or the ones at the bottom here, are actually commonly used by men who are used in men to help regulate prostate health. So men who have been diagnosed with oversized prostate or early prostate cancer quite often take alpha-5 reductase inhibitors, and they are used to prevent testosterone and converting into DHT, which then is related obviously to male hormone-driven cancers. But in the case of women, this is to sort of block the activity of testosterone. So it's quite often used in sort of managing sort of issues with excess hair and acne. Sorry, that was on the tip of my tongue there. And then we move over to the other side here. So when it comes to women who are aware that they have PCOS and they are trying to conceive, a little bit too far there, quite often drugs come in at this play which will help women to have a normal sort of ovulation. So these are used primarily in IVF, for example. So there are a few kind of drugs and bits and pieces that are used in treating or managing PCOS. Okay, so when we are looking at sort of diet and lifestyle interventions, one of the kind of key factors that we really need to look at is how we look after all the kind of associated sort of symptoms and factors. So I started off talking about PCOS and obesity, and the two pretty much go hand in hand. It's thought that around 30 to 75% of PCO cases are either overweight or obese, and this is going to put them at risk of developing metabolic syndrome. And again, this is really common in women with PCOS. And again, metabolic syndrome is one of those kind of hidden syndromes that you might not necessarily know that you have. Some of the sort of outward signs could be suggestive. So, the weight gain, the visceral, the abdominal obesity is one of the key factors. Then high levels of triglycerides, cholesterol, high blood pressure. This is all going to be increasing our risk of cardiovascular issues. And then obviously we've got insulin resistance, glucose intolerance, and all of these factors together really kind of add up, and we see this sort of pro-inflammatory state, a pro-thrombotic state. So it puts us at a higher risk of inflammatory-driven conditions, pro-inflammatory driven diseases, and obviously sort of things like cardiovascular disease, dementia, and so on. So again, this is quite common in women with PCOS. And if we actually just have a quick look at what happens, what effects of obesity, what is it that what is obesity doing when we're talking about hormone production? So when we've got excess adipose tissue, it produces in excess enzymes that are required to convert the androgens into testosterone and estradiol. So to sort of cut a long story short, we produce more enzyme than we should do, and we produce more testosterone and more estrogen. Obesity also leads to a state of insulin resistance, so we get higher levels of insulin. Insulin then impacts on the liver. The liver then doesn't produce enough sex hormone binding globulin. So this is our testosterone and estrogen chaperone. So sex hormone binding globulin levels are low, which means that we have even more bioavailable amount of estrogen and testosterone to float around and then start to sort of target our cell tissues. So we've got all these kind of things going on. And so we know that having higher levels of testosterone and higher levels of estrogen can increase our risk of a number of different cancers. When we're talking about sort of women's cancers, again, it's, things like endometrium, breast, ovary, that kind of thing. We also have we have issues with insulin and insulin growth hormones as well. So again, when we've got a little bit more weight than we should do, this sort of visceral adiposity that we see, we get higher levels of free fatty acids, we get pro-inflammatory cytokines like TNF-alpha, and we get resistin, another pro-inflammatory cytokine. We also get lower levels of adiponectin, and this is a really important protein that is involved in glucose regulation and fatty acid oxidation. This then leads to more insulin resistance, and we get hyperinsulinemia. Increased levels of insulin then leads us to reduced levels of insulin-like growth factor binding protein, which plays a role that is similar to sex hormone binding globulin in that it sort of chaperones growth hormones. So if you've got low levels of insulin growth-like hormone binding protein, then you're going to have higher levels of insulin growth factor, and our insulin growth factor then is able to interact with our target cells. Higher levels of insulin also is able to target our target cells. We get low levels of apoptosis, we get increased cell proliferation, and we get our tumor development. So carrying a little bit too much weight, or being sort of obese, not only increases insulin, but it also increases growth factors. So these are not good. So we need to be looking at ways that we can manage this. And then when it comes to sort of how this then impacts on things like sort of cancer, just a little slide here to sort of give you an overview of the impact that this has on endometrial cancer. So when we're looking back at PCOS, Endometrial cancer seems to be the kind of the primary cancer that there is an increased risk of. So the breast cancer and ovarian cancer as well, but endometrial cancer seems to be a key player here. So we get high levels of insulin, increased levels of insulin growth factor. This leads to chronic anovulation. And then we kind of start to be able to look at the relationship with progesterone here as well. So we get a progesterone deficiency. Progesterone normally counteracts the effects of various sort of mechanisms and pathways that are involved in tumor progression. The lack of progesterone itself actually then reduces the amount of insulin growth factor binding protein, which then has another impact by increasing insulin growth factor. So it's kind of a bit of a vicious circle here. But high insulin reduces concentrations of sex hormone binding globulin, which increases the bioavailable estrogens that can then diffuse into the endometrial tissue. So it's all about looking after our insulin. So reducing insulin seems to be key. Okay, so we've talked a little bit about sex hormone binding globulin, so let's talk a little bit more about how we can influence it. So we know that sex hormone binding globulin concentrations negatively correlate with body mass. So the bigger you are, the lower your levels of sex hormone binding globulin. We also know that certain aspects of our typical standard Western diet are also associated with high levels of estrogen or estradiol and also lower levels of sex hormone binding globulin. But carbohydrate seems to be a key player here. So if you eat a high carbohydrate diet, or if you eat a diet that is high in refined grains and simple sugars that elicit a high insulin response, then you're going to naturally lower your levels of sex hormone binding globulin. And this is because we get increased fat synthesis in the liver. And this shuts off genes that are actually involved in making sex hormone binding globulin. And one of the key factors is actually not just glucose, but fructose as well. Fructose stimulates hepatic lipogenesis, reduces sex hormone binding globulin, and it's about reducing or downregulating hepatocyte nuclear factor 4 alpha. And this is the key transcription factor that plays a role in the expression and the synthesis of sex hormone binding globulin. The other thing that fructose does, and glucose to an aspect as well, is that because it increases fat levels in the liver, it increases inflammation. So we get an increased level of cytokines, again, tumor necrosis factor, interleukin-1 beta, and these then induce a further downregulation of hepatic sex hormone binding globulin. So inflammation, high carbohydrate diets, are all going to impact your levels. So addressing, and this seems to be sort of one of the key sort of areas when we're looking at sort of interventions, is not just about reducing your carbohydrate intake, but actually the type and amount. And this seems to be a key target, certainly when it comes to nutritional intervention. And I'll show you some studies shortly looking at the impact of low carbohydrate ketogenic diets and the impact that they have not only on sex hormone binding globulin, but also insulin and adiponectin as well. Because that's our next little factor to look at. Low adiponectin is also associated with a low level of sex hormone binding globulin. And there are lots of things about our diets that influence adiponectin. One of the first things is that levels of adiponectin are associated with high BMI. So the bigger you are, the less you have. And again, metabolic syndrome seems to be characterized by reduced levels of adiponectin and increased inflammatory adipokine secretion, as well as low sex hormone binding globulin. This, alongside the downstream effects of insulin resistance, leads to high levels of inflammation, prothrombosis, vasoconstriction, all associated, of course, with sort of poor cardiovascular health and so on. So your sort of adipocyte, your inflammatory adipocyte, is going to not only decrease adiponectin, but it's going to increase a lot of factors that are pro-inflammatory as well, which is going to then have an impact on insulin resistance as well. So it kind of exacerbates that whole kind of area. Okay, so adiponectin influences, so we go back to how adiponectin then leads to improved fertility. Okay, so if we look at adiponectin and how it actually influences the hypothalamic pituitary gonadotrophic axis, when adiponectin is low, we get a persistently rapid LH pulse frequency, and we have impaired follicle stimulating hormone production. So this kind of all goes through back to how we have inadequate follicular development. As we know, in PCOS, we have high LH and low adiponectin, and this exacerbates the ovulatory issues that are observed in PCOS. So basically, if you've got low adiponectin, you're gonna have repeatedly high levels of LH and low FSH. If we can increase adiponectin, we can actually increase sex hormone binding globulin as well. So the two kind of go part apart. That they kind of sort of hold hands in this sort of relationship, influencing each other. So we know that adiponectin regulates sex hormone binding globulin production. Not only does it play a role in lipogenesis and fatty acid oxidation, but higher levels of adiponectin reduce lipogenesis and increase fatty acid oxidation, and vice versa. So it's not good to have low adiponectin, but this causes a reduction in the hepatic fatty acid pool, and as I said, this increasing HNF4 that then actually increase sex hormone binding globulin production. So basically, adiponectin switches on the genes that are involved in making sex hormone binding globulin. So if we get adiponectin levels up, then this is going to increase sex hormone binding globulin levels, and if we can increase that, we can decrease some of our testosterone and androgens, which is going to have a knock-on effect in improving fertility. It's going to help have a knock-on effect in sort of improving some of the sort of physical characteristics, so kind of the unwanted hair, the acne, and that kind of thing. Okay, so so adiponectin as well, not only is it involved in sex hormone binding globulin protein and that kind of thing, but it's actually known to be involved in lots of sort of pro-inflammatory and anti-inflammatory pathways as well. So if you have low levels of adiponectin, and this is in combination with high levels of oxidative stress, which is often the case, then this increases the risk of a number of obesity-associated metabolic, cardiovascular, and cancer issues. And I think I'm exhausting adiponectin here, but basically adiponectin is generally thought to be anti-inflammatory. So if we have low adiponectin, then we increase and switch on various genes, including nuclear factor kappa B, that are involved in sort of promoting pro-inflammatory pathways. And we also suppress, if you can increase adiponectin, then we can inhibit nuclear factor kappa B activation, we can suppress inflammation. So it's all about increasing adiponectin and sex hormone binding globulin and decreasing androgens and insulin. Okay, so the next little area that I'm going to mention, I'll be a little bit briefer about homocysteine, is the relationship between homocysteine and PCOS, because there seems to be a disturbed homocysteine metabolism in these individuals. And this is partly due to the fact that insulin resistance is associated with increased plasma homocysteine. So it's quite often that women with PCOS have high levels of homocysteine. And we know that, if we have poor methylation recycling, or if we have high levels of homocysteine, then that's going to have an impact on many different pathways. What is also quite interesting is that women with PCOS tend to have or are predisposed to having higher homocysteines, having higher homocysteine levels. This is not just about insulin. This is actually about the methyl tetrahydrofolate reductase polymorphism. So if you've got the TT genotype, you are at a higher risk of having higher homocysteine. So you have about 20% higher levels of homocysteine. And this is what we see in individuals with PCOS. So they're kind of double attacked here. Not only are they predisposed because of their sort of genetics, but actually having higher levels of insulin is going to impact on homocysteine levels as well. And then my little diagram here really to sort of highlight the or expand really on all the issues that are going to happen. If you don't have homocysteine recycling, then you're going to have poor levels or reduced capacity to make glutathione. You're going to have reduced capacity to produce methyl donors. And then you're going to have all these pathways that are going to be impacted on as well. So we can start to kind of expand out and have a look at how things like high levels of oxidative stress, high levels of inflammation, high levels of sort of cardiovascular risk factors can all have an impact here. So, I mean, even if we just look at the impact that homocysteine has, we know that having high levels of homocysteine itself is a risk factor for the development of cardiovascular disease, all through sort of issues with sort of cholesterol, blood clotting, endothelial dysfunction. If you have high levels of homocysteine, that's going to then predispose you to an increased risk for vascular dementia. Homocysteine itself is neurotoxic. So again, the oxidation product of homocystic acid, is an excitatory neurotransmitter, activates NMDA, enhancing calcium inflow. This damages our neurons, leads to cell death. And the impact of that basically is that this then is going to sort of predispose us to things like dementia. It's also associated or can be linked through to some of the sort of mood issues and the sort of cognitive dysfunction that we see in individuals with PCOS. So it's not surprising also that women with PCOS have low-grade chronic inflammation and high levels of oxidative stress. So this was a study that was published fairly recently, actually, within the last sort of 5 years. And it was I think it was a meta-analysis actually looking at various inflammatory markers found in PCOS. So again, so homocysteine tends to be high, malondialdehyde, which is end product of lipid peroxidation, primarily from arachidonic acid, that's high. We've got low glutathione, we've got various sort of aspects that are related to low-grade chronic inflammation that are observed in individuals with PCOS. And also levels of C-reactive protein are also higher in PCOS, which then has a kind of a knock-on effect because CRP itself triggers this sort of cascade of pro-inflammatory events. So for anybody who attended Sophie's webinar a few weeks ago, she was talking beautifully about the relationship between oxidative stress and inflammation, and how when we see oxidative stress as a primary disorder, then inflammation develops as a secondary disorder, and vice versa. So we have this kind of sort of domino effect and sort of a backward domino effect, I suppose. But where you have inflammation, you have high levels of oxidative stress, and where you have oxidative stress, you're going to have inflammation. So we need to be kind of, and because both of these are associated with PCOS, and these are going to be driving some of the other kind of aspects of PCOS, then we need to be looking at managing inflammation and oxidative stress in individuals. Oh, okay, so this is linking me through as well. So I was talking earlier about the impact of NMDA agonists, so homocysteine, but there are other ones as well. So when we got high levels of cortisol, when we got high levels of pro-inflammatory cytokines, we shift our tryptophan pathway down the kynurenine pathway, away from serotonin, and this could potentially kind of explain some of the issues that we see with sleep disturbances, mood issues, and the potential sort of issues that we see with cognitive decline. Anything that's going to sort of damage neurons is ultimately going to have a sort of knock-on effect and increase our risk for sort of dementias later on. So again, reducing inflammation is really key. And just to sort of really highlight as well, so where we have metabolic syndrome and hypertension, dyslipidemia, diabetes, and factors like that, we're going to see things like vascular damage. We're going to have microglial activation. This is going to lead to demyelination of our poor little neuronal networks. We get hypometabolism, so poor old brain is starved of glucose. This is primarily kind of when we're looking at also at insulin resistance as well, which is quite common. So if you're insulin resistant and we get sort of we start looking at sort of insulin signaling in the brain. If you get a reduced insulin signaling in the brain, it increases activities of things like glycogen synthase, kinase. This is associated with things like tau, high phosphorylation, neural death, decline in cognitive performance. Impaired insulin signaling in the brain also is involved in upregulating beta secretase, which is involved in things like amyloid beta formation. So we can kind of start to sort of piece it all together when it comes to how metabolic syndrome, diabetes, those kind of things start to predispose us to sort of cognitive impairment and dementia risk as well. So moving on to some sort of like nutrient deficiencies and things like that. One of the kind of key areas, and I think we're all sort of fairly knowledgeable now about just how common vitamin D deficiency is, certainly within the UK. We've had enough sort of newspaper headlines blaring it out at us. Everybody's popping vitamin D supplements now like Bilio. But observational studies show that low levels of vitamin D are associated with both insulin resistance, ovulatory and menstrual irregularities, lower pregnancy success, and a lot of the sort of factors that are associated with PCOS. And it's believed that very high numbers, anywhere between 67 and 85, that's very precise, of women with PCOS tend to have serum concentrations that are considered to be insufficient. So actually, if we can increase vitamin D levels, we can start to sort of look at, my little diagram here is giving you an outline of how vitamin D, or the role that vitamin D deficiency plays in things like some of the sort of high levels of androgens that we see, the insulin resistance and the infertility issues that we see in PCOS. So possibly actually sort of just vitamin D supplementation will be a sort of key thing to think about. So kind of talking about what's going on in PCOS and the surrounding kind of issues that are associated with PCOS. So now we're going to have a quick look at what we need to do to manage the condition. So the first thing that we need is we're looking at reducing inflammation and reactive oxygen species. Managing insulin resistance, because if we can improve glycemic control, we increase both adiponectin and sex hormone globulin binding protein. That's the wrong way around, isn't it? Yeah, I don't know what SHGB is. And again, if we increase that, we can improve hormone regulation. And if we can increase adiponectin, and I've talked about it a lot now, but we increase sex hormone binding globulin, we can lower things like triglycerides, free fatty acids. And if we increase adiponectin, we decrease oxidative stress and inflammation. Homocysteine, if we look after our methylation cycle, or if we regulate our homocysteine, keep that in check, we not only support methylation, but we also support transfer, sulfuration and sulfation pathways, which are all very important. And then weight loss. And if anybody with PCOS goes to see their GP, the first thing they'll probably get told is weight loss is going to be sort of key to improving. And one of the things that I kind of said when I first started the webinar was that a lot of women with PCOS who have weight issues actually find weight loss extremely hard. So whilst sort of saying to somebody, well, you just need to lose weight, there's a lot more to it than just that. But the evidence suggests that even as much as 5% or as little as 5% of their initial weight loss can show as improvements in both circulating androgen levels, and it can decrease levels of circulating insulin as well. So if we're looking at insulin as a key role player in sort of androgen excess, then decreasing insulin is certainly worthwhile. Okay, so yeah, let's have a little chat about weight loss or weight and diets and things like that. Focus on weight loss, improve insulin signaling. Okay, so we know that PCOS is coupled with weight gain, which drives insulin resistance. Dietary intervention should aim to promote weight loss and reduce insulin. And if we can do that, we reduce the health burden associated with insulin resistance, so things like metabolic syndrome, type 2 diabetes. If you regulate insulin, you improve hormone status, and then you can kind of blunt this insulin PCOS cycle. And there is certainly evidence to suggest that improved insulin actually does this. So weight loss, improved insulin signaling, and so on. And there have been a few studies published, which I've just included very briefly here, showing that low carbohydrate ketogenic diets lead to significant improvements, not only in glycemic control, but in other factors as well. So lowest pro-inflammatory end products. We also, there was a study, the final one at the bottom there was a 6-month study looking at weight loss and in regards to sort of improved fatty liver disease as well. So there is a lot of evidence out there to suggest that actually low carbohydrate ketogenic diets can lead to weight loss, which then lead to improvements in many of the sort of symptoms and health areas related to PCOS. And then one of my kind of favorites really is obviously the Mediterranean style diet. I mean, this is probably one of the kind of key things. If we all followed this, then we'd all be a lot healthier. But so the Mediterranean diet was, as you're probably all aware, it was first described in the 7-country study back in the 1950s, 60s. South of Europe, adult life expectancy was among the highest in the world. Rates of things like heart disease, cancers, other kind of nutrition-related chronic diseases were among the lowest. So when we talk about Mediterranean-style diet today, it's going to be a little bit different to how it was. Obviously, Mediterranean-style diet 40, 50 years ago, 60 years ago, maybe even now, was very different. So everything was kind of very locally sourced. You had your neighbor who grew the chickens, raised the chickens. Then your other neighbor would have the goat to make the cheese, and everybody was kind of had this wonderful relationship. There was a lot of swapping going on. Everything was organic, nothing was tampered with, there was no processed foods, a little bit of red wine every now and then, moderate intake of dairy, low stress, everybody have a little snooze in the afternoon. But the impact of the Mediterranean-style diet on things like type 2 diabetes and metabolic syndrome is well established. In fact, there was a study published very recently. It flagged up on my news alerts today, supporting, or a study that's come out supporting the Mediterranean style diet for rheumatoid arthritis. So that the kind of anti-inflammatory benefits, and certainly when it comes to things like sort of improving glycemic control, lowering insulin, all the kind of cardiovascular things, low levels of oxidative stress, low levels of inflammation, blood pressure, everything is really wonderful and all kind of sorted out. So actually, if we look at a Mediterranean style diet that also takes into account the kind of carbohydrates then we're eating, then we can certainly improve kind of insulin signaling, glycemic control, cardiovascular sort of health risks. And when we look, and for anybody who's come to one of my webinars before, you might have seen this slide before, but we look at the components of these kind of diets, we can start to sort of unravel exactly what's going on. And I think what's really important to sort of highlight here is that you don't just take one nutrient or one food group and say, right, eat this, this is going to do this. It's this synergistic relationship that these foods have with each other. So we have high levels of polyphenols, where they're nutrient rich, they're high levels of antioxidants, quality amino acids, quality fats, that are going to have an impact on lots of different systems, that are then going to have an impact on the whole body systems. So by incorporating sort of healthy diets like this, we can see these sort of like long-term health benefits. So if we kind of do narrow it down slightly, so let's pick out a few bits that we know that are within these kind of health promoting diets, and have a look at what they're doing. And one of the impacts that something like Mediterranean style diet is that it increases adiponectin levels. And close adherence to a Mediterranean style diet has been shown to produce higher levels of adiponectin. Where you have higher levels of adiponectin, you're going to have higher levels of sex hormone binding globulin. That's going to have a knock-on effect because it's going to drag all your androgens out and make those behave. So actually, yes, I think there are lots of very positive things about Mediterranean style diets. But yes, if we break it down, high in fish. Fish has been shown to, or fish consumption, high levels of omega-3 can increase adiponectin levels from anywhere between about 14 to 60%. And I've repeated that twice for some reason, but there we go. Weight loss, obviously, Mediterranean style diets, just through the kind of characteristics of them, can actually help people lose a little bit of weight as well. So if we achieve a bit of weight loss, that increases adiponectin. And then one of my favorite subjects, the polyphenols, anything through from resveratrol to EGCG, so green tea extract, curcumin, are all known to increase adiponectin, and actually they all act as 5-alpha reductase inhibitors as well. So they stop testosterone doing naughty things and making us hairy and giving us acne and that kind of thing. And as well, if you increase fiber, so good quality fiber, so even something like inulin, supplements can help to increase adiponectin as well. And obviously, if you've got diets that are high in fiber, we're going to sort of improve our transit time. If we improve our transit time, then we're going to flush out all of our nasties and toxins and excess levels of hormones as well. So yeah, high fiber is good. So if we look at our little polyphenols, and these are found in so many different foods, as long as you're not sort of processing it and buying it out of tins and things like that. If you're eating quality food, nutrients, proper food, vegetables, fruits, then you are going to be getting a good dose of polyphenols. And if we look at the flavonoids, we've got things like EGCG, just drinking a cup of tea every now and then. We've got curcumin, we've got resveratrol, but they're all sort of throughout our diets, and we can increase these kind of factors quite easily. Didn't need to do that. Oh, what's going on? Right, there we go. Okay, so And one of the really good things about things like green tea extract, resveratrol as well, there have been some really nice meta-analysis published that have shown that regular consumption of, and I'm not talking about sort of doing too much boozing, but moderate intake of resveratrol through either through supplements or through sort of moderate intake of red wine and green tea extract as well. So cups of tea or EGCG supplements not only have favourable effects on fasting glucose, but improve insulin sensitivity as well. So quite the sort of optimal doses needed is not quite clear. Some of the meta-analysis, certainly the green tea meta-analysis, is very difficult to sort of work out exactly the kind of dose. The range from intake of EGCG from study to study was quite large. So actually working out the required dose to have an effect would be interesting to know, let's put it that way. But just sort of increasing things like green tea, a little bit of resveratrol can help improve insulin sensitivity and glucose control. So if we're thinking of these as kind of primary sort of interventions for managing PCOS, then it's going to be a good one. And then just a little slide here to because I'm not quite sure what dose we need, but give you an indication of where to get your EGCG if you are sort of thinking about sort of cups of tea and that kind of thing. Have to be a little bit careful, obviously, because there's caffeine there. We don't want too much caffeine, and we have to be a little bit careful about sort of green tea catechins because they have an affinity for iron. So we just have to be a little bit careful. But if you choose our green tea appropriately, we can get a relatively good dose in there. So fermenting the leaves reduces, so green tea, not black tea. And then again, this is my hot favourite at the moment. As probably a lot of you are aware, we've introduced curcumin to our stack range, and the feedback that we are getting is really rather lovely, I have to say. So curcumin, as I said, is one of my favourites. And it's been used in sort of like herbal medicines for a very long time. The issue with curcumin obviously is the sort of poor bioavailability, but we've overcome that with our long vida. But the benefits of taking curcumin are rather large. So the first thing it does is not only does it help reduce oxidative stress, but it upregulates a lot of our endogenous antioxidant defenses, so things like glutathione, for example, and cassonase as well. So these are all really important. So this is our kind of army of defenses against the onslaught of oxidative stress, which we know is associated with PCOS. Nice little study published a little while ago in 2012. It's quite generic, but I thought I'd include it anyway because it kind of covers so many factors that are associated with things like PCOS and metabolic syndrome. So just one little capsule of long vida curcumin can improve things like amyloid beta aggregation. It lowers triglycerides. Improves things like catalase activity, so our antioxidant enzymes are increased. ALT, which is a marker of liver injury, so we know that PCOS and non-alcoholic fatty liver disease are closely associated. So there are lots of benefits from having curcumin supplementation. Obviously, we can include this in food as well, but we just have to be a little bit sort of aware that curcumin in food probably not going to get an awful lot into our systems. Okay, so I just thought I'd have a chat about a couple of the sort of more physical aspects of PCOS. I'll talk about acne in just a minute, but I thought I'd just include a little slide here about the issues related to sort of having this sort of high levels of sort of unwanted hair. And again, this can be quite distressing for many women. Now, there are drugs available, and I mentioned quite early on about, I think it's pronounced finasteride or something like that. It's used quite commonly in the management of sort of prostate cancer and in the treatment of enlarged prostate, but it is quite regularly used in PCOS. There are a few natural alpha 5-alpha reductase inhibitors. One of the best known is actually saw palmetto. This is used quite a lot by men trying to stop themselves going bald, but it is quite effective. Now, it's a 5-alpha reductase type 2 blocker. Now, I was trying to do a little bit more research, and I was trying to work out the difference between type 1 and type 2, because the literature tends to suggest that type 2 blockers are more favorable to men, whereas women tend to need to have 5-alpha or the type 1 5-alpha reductase blocker. So how effective saw palmetto is for women, I'm not quite sure, but I do know that EGCG definitely has type 1 reductase activity. And then we've got other natural kind of components of food. So we've got beta-sterol, that's known to reduce 5-alpha reductase. Genistein, gamma, GLA, found in even primrose oil, ginkgo bilinco as well. There's some evidence there. So sort of some natural ways to maybe sort of intervene here as well. Probably one of the next biggest burden of the sort of physical characteristics maybe of PCOS is the sort of the acne side of it. So again, there are 4 factors that interact to produce acne, and they range from excess sebum production, colonization of the follicle by bacteria, altered keratinization, and release of pro-inflammatory mediators into the skin. So you get all of those four, and then we get our different types of acne. And there are lots of factors, so it's not just PCOS that is associated with acne. There's a lot of people with it. Things like diet, hormone balance, inflammation, insulin, digestion, allergies, intolerance. Lots of things can play a role in acne. But when we have a quick look at how diet interacts, then we can sort of start to look at how we can make or give advice or sort of modifications through diet itself. So we know that is well established that vegetable oils, intensively farmed animals products can increase our omega-6 to omega-3 ratio, primarily AA to EPA. This is going to drive inflammatory processes. We've got things like leaky gut, dysbiosis, high levels or low levels of stomach acid can all have an impact on micronutrient uptake. This is going to have an impact primarily on things like methylation, sulfation, glutathione production. So we're going to get high levels of oxidative stress. We get inhibition of key enzymes and so on. But if we just kind of concentrate on the top one, so we're looking at things like high levels of gluten, so knocking out grains. If we have dairy from intensively farmed animals, this is probably more related to high levels of IGF that are used in intensively farmed animals. And then we've got refined grains and sugars and protein-rich dairy. They tend to increase insulin and elevate IGF-1. Anything that increases testosterone is then going to kind of increase sebum production. So we kind of make some dietary modifications here. We can actually sort of decrease our sort of acne issue. So, moving on to some other areas that the sort of interventions, I guess, or dietary interventions for managing PCOS. This is the one that really strikes me because there's an awful lot of evidence out there on the use of inositol. Now, inositol is a component of inositol phosphoglycans, and these act as second messengers in insulin signaling. And it's kind of suggested that maybe in PCOS there's a defect in tissue availability or altered metabolism of inositol or IPGs, and this is thought to then contribute to insulin resistance. So lots of studies, and there's quite a nice little review that I've kind of summarized in this slide here, that has shown that studies that use mito-inositol anywhere between 2 to 4 grams a day over a period of about 12 to 16 weeks And I'm reading this and I'm thinking, really, they're making some pretty hefty claims here. But they suggest that intervention with inositol is capable of restoring spontaneous ovarian activity and improving fertility in many patients. They actually put most, and I was a bit reluctant to write the word most because I'd like to actually sort of see this intervention work myself. But basically, the study implies that if you take inositol between 2 and 4 grams over a period of about 3 months, you can restore your LH-FSH ratio, you can reduce your testosterone levels, and that's total and free testosterone. You restore normal ovulatory activity and fertilization rate, you improve insulin sensitivity, and then as a kind of like added benefit, really, or a bonus, you actually see things like reduced cholesterol, LDL, but increasing HDL, and we reduce triglycerides. So when we're kind of looking at the whole kind of metabolic syndrome, sort of type 2 diabetes risk as well, it's all kind of there. This one seems to sort of like tick all the boxes. So it's quite interesting. I don't know if anybody's sort of come across it or used it or had any experience of it, but I'd be quite interested to have some feedback on this because it looks really promising. And there's a lot kind of in the sort of media about it as well. So this is one to sort of like look out for as a sort of supplementary intervention, certainly. And then of course we've got our little favorites, our omega-3s. If you've got low levels of omega-3, then we know that this dysregulates insulin signaling, and this is all about the role omega-3s actually play in regulating cell membrane integrity. So if your cell membranes aren't fluid enough, then your poor little insulin receptor can't work functionally. And if you increase your omega-3 intake, you increase the levels of omega-3 within your cell membrane, you get improved insulin sensitivity. You also get lots of other benefits from it as well. So we lower our C-reactive protein, we get increased or decreased, levels of pro-inflammatory products. So that's just a kind of like little indication of why it's important to increase our omega-3s as well, so we can improve insulin signaling, as well as lots of other things. And I'm only going to use one slide to sort of summarize the benefits of increasing EPA and DHA, or primarily EPA, when it comes to like managing inflammation. So little boxes, I'm not going to read through them all, but when it comes to things like metabolic syndrome, PCOS, type 2 diabetes, we see increased adiponectin, we see increased through that way sex hormone binding globulin. We see all these kind of other factors as well. So improved antioxidant capacity, decreased inflammation, so and improved insulin sensitivity. Yes, so EPA DHA is always going to be one of our kind of top recommendations. If you're not sure whether you need it, you can use our test, and we'll certainly tell you. Chances are everybody's a little bit low. And when we look at studies, so it's all very well kind of saying this is what it does, but have there been any omega-3 interventions? There was actually one published a couple of days ago, which I didn't manage to include in the webinar today. But so that one was I think it was a 12-week study using omega-3s and vitamin E. And again, this one showed significant improvements in insulin resistance and reduced testosterone. So that's always a big one. But the two that I've included here are just relatively kind of small scale, but they do give an indication of what increasing omega-3s. If you look at the dose, it's relatively high, and that kind of indicates that that we do need to have possibly doses that are higher than we would normally sort of take in a sort of conventional diet or conventional sort of supplementation routine. So the first one was 45, and this kind of highlights. So one study was non-obese, because not everybody is obese with PCOS. And then the second one was 32 obese women. So in the first study, 1.5 grams of omega-3 over a period of 6 months. Luteinizing hormone was reduced, testosterone was reduced, sex hormone binding globulin was increased. So they're all going to help to increase our fertility potential. And then the second study, the 32 obese women, again taking a high dose, this time only for 8 weeks, 1.2 grams. We see improvements in adiponectin is increased, insulin decreases, glucose decreases. We've got things like triglycerides, total cholesterol all goes down. The only one that wasn't significant was CRP. So there was a reduced levels of CRP from taking omega-3s, but it didn't reach significance. So there's a lot of importance that should be placed on increasing omega-3 through oily fish as well, and through maybe the sort of add-on supplement can be beneficial too. Moving on to, let's look after our homocysteine. If we look after our homocysteine, then we're going to look after our methylation pathways. N-acetylcysteine, this is a nice one, just really for kind of supporting glutathione, take some of the strain off homocysteine. Creatine, one of my earliest slides I showed you, with there was the picture, or the kind of complex picture showing homocysteine metabolism. And one of the key areas that SAMe plays a role in is obviously as a methyl donor. And there are two areas, two key factors that take up a lot of methyl donors, and that's creatine and phospholipids, phosphatidylcholine. So a lot of the methyl donors are used up, as it were, in creating creatine and phosphatidylcholine. So we can kind of increase these in our diet quite naturally. Then it takes some of the effort away from SAMe having to donate its methyl donor, so it can do other really important things. Choline through we've got soybean lecithin, but we've got sunflower derived phosphatidylcholine as a source of choline as well. Betaine can be quite useful. Betaine obviously is our sort of homocysteine lowering sort of BVIT, if you like, primarily within the liver. Most of the betaine that we can get quite naturally from our diet, but actually a little bit of betaine intake can help to lower cholesterol levels. And then we've got the kind of, the wonderful trio. We've got our folate, and I'll emphasize that sort of methyl tetrahydrofolate or quatropholate is going to be more beneficial, because obviously with PCOS, if we've got issues with methyl tetrahydrofolate polymorphisms, then we want to bypass that, so quatropholate. B12 obviously, and B6. So the reason that there are numbers after these nutrients is these are studies, these are meta-analysis that have shown that doses between 3 and 5, for example, for folate, and between 10 micrograms and a gram for B12, and so on. These are the doses that have been shown to have cholesterol lowering effects. And then obviously, if we want to have a little bit of extra support there, we can add a bit of SAMe to our diets, but I don't think that's legal as such. I don't think it's a legal supplement in the UK. But these are ways that we can lower homocysteine and support methylation, and therefore support our detox pathways and glutathione and everything that's kind of going on there as well. So next, to kind of move on, is we need to look after our oxidative stress pathways. So we either want to prevent, inhibit, or repair. We've got various antioxidants, non-enzyme ones. Our lovely polyphenols. We get our vitamin A, C, E, and so on. And then we've got our enzymic antioxidants. So these are the ones that we can produce endogenously. So as I was saying, things like curcumin are wonderful for upregulating these. They all require a number of cofactors, so it's really important to make sure that we get plenty of these in the diet. And again, it's all right, when we consider that vitamin D is required for these enzymic or antioxidants, we can start to see why, maybe if our vitamin D status is low, that's going to have a knock-on effect. So it's this sort of synergistic relationship that's really important to just acknowledge. Okay, so this is something that's flagging up on our radar. We're considering bringing out an astaxanthin supplement at some point in the near future. We love astaxanthin. Not only is it unique in regards to sort of antioxidants because of its structure, it sits so nicely within the cell membrane. So it's kind of actually antioxidant potential is really quite overwhelming. Its unique shape, it sticks out of the membrane, it sticks inside the membrane, and it spans the membrane. So it's offering antioxidant benefits inside, outside, and it protects our little fatty acids within the membrane itself. And unlike vitamins like vitamin C, vitamin E, that can only kind of manage one free radical at a time, the structure of astaxanthin means that it can sort of quell and quash all these sort of high numbers, shall we say. So when we're talking about sort of the antioxidant capacity of different antioxidants, this is why astaxanthin is quite up there. It's because it's got loads of spaces on it, so it can sort of drag them in and quell them. But obviously, combining your antioxidants is going to be really important. So it's not just a sort of one-all feature here. We have to support our antioxidant defenses, because if we look at how antioxidants work, they go from oxidized to reduce to oxidize. So, you know, you have to have a sort of a good group of friends, shall we say, to help pass on so to pass on. So there's a kind of a knock-on effect, shall we say. So things like, you know, CoQ10, vitamin E, vitamin C, glutathione, all kind of help each other and support each other in supporting our antioxidant defenses. And again, alpha-lipoic acid is one of our favorites. And then you've got sort of like the more simple ones, vitamin C, vitamin E. They're easy to get into our diets, but they're also pretty easy to sort of incorporate into a supplement as well if you need that little extra boost. And then again, this is something that we've had within our range for some period of time now. CoQ10 can be quite beneficial for people with PCOS. Again, I was talking in one of my earlier slides about, you know, individuals with PCOS tend to have issues with fatigue, they don't sleep well, low energy, and this can be related to CoQ10 as well. So CoQ10 supplements, as you are aware, not only are they incredibly efficient in increasing ATP and so energy production, but they're also fantastic antioxidants. So this was just a brief study, really. It was a 12-week study, numbers quite small, given 100 milligrams of CoQ10, and not only did it significantly reduce their, it decreased plasma glucose levels, decreased insulin concentration, improved insulin sensitivity, but it also helped with things like cholesterol as well. But it's going to give sort of some really kind of powerful benefits in regards to sort of energy as well. But as an antioxidant, yeah, it's pretty spot on. When it comes to reducing inflammation, there are a couple of really nice meta-analyses. We might have shown you these slides before, showing that CoQ10 lowers CRP, it lowers interleukin-6. So CoQ10 supplementation is incredibly effective at lowering both oxidative stress and pro-inflammatory. So if you think about our sort of oxidative stress, our inflammatory pathways having this wonderful relationship, go in there with some CoQ10 and you're going to handle both of those. Mentioned acetylcysteine a little bit earlier. Again, this is something that's kind of on our radar as well. Wonderful as an antioxidant for supporting glutathione. People say, well, why don't you just use L-cysteine? Because L-cysteine is obviously the rate-limiting amino acid involved in glutathione production. Cysteine isn't awfully effective because it reduces it, or it loses its sulfur groups when it's digested, whereas N-acetylcysteine is very stable and only loses minimal amount. Not only does it reduce homocysteine levels, increase glutathione levels, but it also helps to inhibit the oxidation of LDL, and it increases HDL cholesterol. So it's all good there. Quite often it's best to supplement with L-cysteine in combo with other nutrients as well. So again, it's this kind of synergistic. So this relationship that things like alpha-lipoic acid and vitamin C have in sort of regenerating itself and regenerating glutathione is really important. So I mean, we all know about liver health. One of the sort of big factors really is, we talk about all these other factors, but liver health is really, really important, not only for sort of looking after sort of inflammatory pathways, but for sort of detoxing as well. A lot of our hormones are excreted or managed within sort of phase 1 and phase 2 pathways. So if we don't look after our liver health, then we are going to have issues with sort of excess hormone, androgen excess as well. So look after your liver. And this slide is quite famous. You've probably seen it before, but it gives a kind of indication of the nutrients that are needed. So we're looking at things like, the ones that we've mentioned. So N-acetylcysteine, we've got glutamine, we've got sort of our B-vits and so on. We've got all of our sort of various sort of nutrients, vitamins, minerals and so on that are needed to support both phase 1 and phase 2, make sure that our liver is working optimally, especially if we've got sort of high, if I've got sort of high fat diets and things like that, which can and high carbohydrate diets that put excess stress on our liver. Okay, so this is moving towards the end of the webinar now, but it's just something I thought that I would mention. And I've kind of been looking at into this kind of area quite a lot recently, actually. But this sort of dysbiosis that is associated with obesity and associated with things like metabolic syndrome, that then predisposes us, the way that our guts and our brains and all of these kind of pathways all sort of intermingle with each other. Looking after our guts is incredibly important. And one thing that is really, really clear is that there are issues with dysbiosis, not only in sort of obesity, which is linked through to sort of predisposing people to sort of full-on diabetes, but we've seen that dysbiosis is actually quite common in obese PCOS women as well. So looking after our guts is just as important. And so, this was just a little slide just sort of highlighting the sort of factors that influence dysbiosis as well. So I think I've kind of covered all of that. And again, sort of the balance between the good guys and the bad guys predisposes us to an awful lot of different inflammatory diseases and conditions, obesity, type 2 diabetes, metabolic syndrome, changes in sort of bacterial species is going to drive all of these kind of oxidative stress pathways. It's going to increase inflammation. It's going to exacerbate everything. So getting a little bit of good gut routine, improving gut health. Again, we're all kind of fairly familiar with what we need to do. So it's kind of making sure that we get good probiotics, we get good source of sort of fiber containing carbohydrates, so short chain inulin, sort of, for example, FOS and GOS, and fermented foods. So we're all sort of eating our kefirs and yogurts and sauerkrauts like Bilio in the office, keeping our guts healthy. So for the PCOS woman, actually having a little bit of gut care is going to be incredibly helpful as well. And so we're kind of rounding up really now. So hopefully I've given you a little bit of information here on some of the factors that are not only driving PCOS, but actually associated with PCOS and the associated conditions, I guess. And the strategies, I guess, as practitioners is we need to downregulate inflammation, look after our oxidative stress pathways. We need to look after those. Insulin resistance, improving glycemic control, increasing adiponectin, sex hormone binding globulin, really, really important as well. My GBs are all over the place. This is not good, but I do apologize. Adiponectin. Okay, so again, if you've got higher levels of adiponectin, you tend to have lower levels of things like triglycerides, free fatty acids, and that's because of the role that adiponectin plays in glucose control, beta oxidation, those kind of areas. So we get a decrease in oxidative stress and inflammation if we can get our adiponectin down. Part of the way that we do that, obviously, is going to be with a little bit of weight loss if we can. So even, again, repeating here, but as little as 5% initial weight loss can show significant improvements in things like androgen levels, insulin, and that in itself is going to have a knock-on effect. And of course, regulating homocysteine to support methylation, transsulfation, and sulfation pathways is really important too. And then this is a little, I nicked this one from Sophie the other day and then added a little bit to it, but basically it's all about synergy. We have to, it's not just about sort of taking one thing and expecting it to really have massive results. What we're finding is that, as an add-on to good diet and practices, when we're looking at dietary interventions through supplementation, it's really, really clear that combining nutrients will act on converging anti-inflammatory pathways and so on to enhance anti-inflammatory properties as compared to the action of a single nutrient. So we see all these kind of studies that sort of come out and they sort of throw in a single nutrient. They don't get the result that they want. But basically, if we start to sort of open up the big picture and have a look at the knock-on effect that actually, say, vitamin D is having or omega-3s are having, or that kind of thing, we can start to sort of build this picture of how to manage conditions, not just PCOS, but an array of sort of common sort of Western style diseases and conditions and things like that. So combos. Oh, I've gone away. Right, okay, moving on. So at the moment, this is kind of the top synergistic nutrients that we would probably go for. So I did talk about the benefits of inositol, and for those of you who are interested in that, it might be worth having a little look at that if you are, or if you have somebody coming to you that has PCOS, might be worth looking into. But at the moment, the benefits of sort of brain structure function, anti-inflammatory, immune boosting, that Farmipa Restore, Farmipa Maintain are going to be offering, get your fatty acid levels up, and you will improve things like insulin sensitivity and so on. You're going to reduce inflammation, reduce oxidative stress. I've got a lovely Vesisorbubiquinol, which is going to, again, anti-inflammatory, antioxidant and so on, energy boosting, lots and lots of health benefits. And then our Super B complex. I mean, again, the feedback that we're getting on this one as well, it's not often that we get complimented when somebody kind of says, well, I took it, I didn't expect it to work, but my word, it has. And that's really lovely kind of feedback that we're kind of getting, is that, that people take the products and they feel the difference. We are very proud of our formulations and what goes into them. So we formulate for efficacy, and so we are pretty certain that that the health benefits are there. But our Super B complex has premethylated B vitamins, so they're going to be really effective in supporting methylation pathways and so on. And then lovely Longvida curcumin. So this is my favourite at the moment. And my knees are saying thank you. I can bend down onto my knees now and say thank you to Longvida curcumin for the benefits of this one. So I can do things that I never used to be able to do, for a while anyway. So anti-inflammatory, it's gonna increase your endogenous enzymes. It's going to reduce oxidative stress, clears out nasty proteins that shouldn't be in our brains. Pretty good product. And so nice high dose, gets into the bloodstream for good benefits as well. So this is a good one as an add-on as well. And that is the end of today's